If you have a fairly straightforward resuscitation and the outcome is the same, so the patient becomes intubated at the end, let's say your endpoint is intubation. If it was an easy intubation, then both the fairly junior person and the expert person will both have checked that box. Patient intubated, first pass, great. But if you actually interview and try to get into the thinking process behind that expert and that novice, you may see something different. You may see that the novice thought about the plan, successfully went through the plan, intubated the patient, great, but there wasn't a lot of deeper thinking underneath that, right? So maybe the expert thought of that exact same plan, but had a plan B and a plan C ready for when plan A fails, because plan A, though it's going to work 95% of the time, for the 5% of the time that it's not going to work, I don't want to be thinking of my plan B at that point. I want to have already thought of what plan B is going to be.
Hi folks, I'm Dan Dworkis, and this is The Emergency Mind, a space where we bring together lessons from the emergency department and beyond about performance when it matters the most and applying knowledge under pressure. Our guest this episode is Dr. Adam Szulewski, an emergency doctor and an associate professor of emergency medicine at Queen's University in Kingston, Ontario. Dr. Szulewski is the program director of the Fellowship in Resuscitation and Reanimation Medicine, and, as will become abundantly clear in this episode, an absolute expert on cognitive load theory. In this conversation, we talk a lot about decision-making in high-stress situations. We talk about what it means to be an expert and how one measures expertise, and we dig into a really fundamental understanding of cognitive load theory, which helps us understand how we can best learn complicated tasks and then subsequently perform them in high-stress situations. Before we jump into the episode, a reminder, if you're not already, to consider signing up for our Emergency Mind newsletter. It's free, it's awesome. It's called Knowledge Under Pressure, and it does a deep dive into a lot of the topics we cover on these podcasts, as well as collating resources on human performance under pressure from a wide variety of other sources. You can find it at emergencymindcom/signup. Okay, all that said, let's jump into it. I hope you enjoy. Adam, thank you so much for coming on the podcast. I've been really looking forward to talking with you. Your work sounds incredibly interesting, and I'm just really looking forward to digging in.
Well, that's great, Dan. Thanks so much for having me. It's always exciting to chat about the stuff that I'm interested in. So I'm glad that you invited me on. I appreciate it.
Yeah. So to start things off, can you give everybody like a two-line or whatever it is elevator pitch about yourself? Like, who are you? What do you do? And how did you come to start thinking about emergencies?
Yeah, so I'm an emergency physician. That's how I kind of think of myself primarily. But I'm really lucky in the sense that I get to wear a bunch of different hats at work. So there's my clinical role as an emergency physician. I also have the opportunity to do some work on our trauma team, where I'm a trauma team leader, and on our RACE team. The RACE team at our hospital is essentially a critical care response team that other places may have. So that's kind of my clinical work, and really enjoy all aspects of the clinical work. I also run a fellowship program in resuscitation and reanimation medicine, which is a great program for me anyway, selfishly, because I get to interact with and be challenged by a whole bunch of really bright young physicians who are interested in the same kind of work that I'm interested in. So that's kind of the second thing I do. And then I carry a research portfolio as well, where myself and a bunch of us are interested in applying cognitive load theory to the practice of medicine, some simulation education research as well. Yeah, that's pretty much me.
What an incredible package of different pieces to put together into this, sort of melting pot of performance under pressure and providing medical care where it's needed the most. I was actually going to start with cognitive load theory, but you said something quite interesting. Tell me more about this RACE team.
Oh yeah, so our RACE team is a team of primarily critical care physicians and emergency physicians who work in the hospital, responding to inpatient codes in inpatient emergencies. So you can imagine if you have, let's say, a urology patient on the ward who's being treated for his prostate issues, but happens to also have acute pulmonary edema at 5 o'clock in the morning. Certainly the urology team would be involved in helping that patient, but the race team would also become involved as well to provide support and education to the house staff. And to the service. So we would come in as a group of 3. So there's the physician who is on the race team, the race nurse, as well as the race respiratory therapist who attend all calls. And we try to stabilize, resuscitate, and provide some education as well. And then a lot of our job is also logistics in trying to find the best place for the patient. So can the patient stay where he or she is? Do they need to be moved to the step-down unit or to the ICU? And that's kind of the service that we provide and that we add in medical emergencies for inpatients.
And when you respond to that situation, do you immediately take charge of the patient? Are you there as an advisor capacity, or how does that dynamic work in terms of who actually runs the show?
So it depends on the acuity of the patient. So our role primarily is to support the service, right? Because the service at the end of the day, they're the most responsible physician for that patient. But generally speaking, we work a lot with the residents in our academic center, who are the first responders to those types of cases. And if everything is going reasonably smoothly, we stand in the back. We're kind of that 6th person in the room, just providing advice over the shoulder of the resident, supporting him or her and making the decisions that need to be made. And then a lot of my work in those kind of non-acute cases are the behind the scenes logistics. And so I've got the operations manager's phone number tattooed on my palm here, so I can, ensure that beds are moving, beds are being cleaned so patients can be moved as necessary. And I do some of the behind the scenes work there when things are going well. Of course, when things are kind of falling off the rails, or if more support is needed, then I'll insert myself to varying degrees. And it's interesting because, of course, you may have to, as a physician in that position, you have to make a quick judgment about how trustworthy the house staff is who's taking care of the patient. Of course, everyone is generally speaking excellent in doing their best, but sometimes people become cognitively overloaded, and we'll talk about that term, I'm sure, later on. And our role is to try to help to support that person and then hopefully provide them with a good learning experience in the end, because there's always a number of things to debrief about and things that can be learned from a situation like that.
And do you all train together as the race team? Like, do you run drills separate from different areas, or is it just more of like each of you has your own expertise and you come together to work on it?
I think it's a bit of both, actually. So we all have our own expertise. So there are, of course, the critical care docs, the emerge docs, who have a slightly different approach to things. Our nurses are kind of the same throughout, of course, but we do train together. And so in particular, given, the current global pandemic, we've done a number of training sessions to figure out exactly how, we're going to perform airway management for these sick patients and approaches that way. We also have mock code blues that are called overhead once a month. Our resuscitation fellows, in particular, are the ones who run those. But for mock code blues in the hospital, we have the race team arrive and again help support the resident who's carrying the code blue pager at the time. And so we do simulate. Essentially, it's in situ simulation that we do for those types of events as well.
So it strikes me that something we've talked a lot about over the course of the podcast is the difference between a well-established, well-put-together team that trains together, lives together, and sort of drives together. And you can think about that model as something we were talking about recently, the book Turn the Ship Around by David Marquette, who was the commander of a U.S. nuclear submarine and lived and worked with the same group for approximately 9 months to sort of change the culture of the organization. On the other end of the spectrum, you have what you'd call a flash team, an X team, or a swarm team, right? Where people come together ad hoc for a particular reason. They maybe don't know each other. They each have different training sets and skills, and they come together to perform a certain function and then dissipate usually afterwards. And that's something that's more of like what the Mission Critical Teams Institute talks about. And that's a lot of the way that we run a code blue model in most of the hospitals that I work at. So maybe you'll get the ER doctor and like one other person that comes from the ER to that situation. But generally speaking, that doctor arrives, takes over the scene, and knows nobody else there, and then disappears afterwards. But what you're describing is really interesting. It's sort of a third model. It's sort of a semi-swarm team, which is that you all come with a unit, and that unit knows each other and trains together for this purpose. And then you interface with staff that maybe you know, maybe you don't. And then you see part of your mission as not only stabilizing the patient, but educating and improving all of the staff around you. That's actually really cool and not something that's come up before on the podcast, that particular model of doing it. How conscious was that? When you guys designed that, or I don't know if that predated you or not, but when you all designed that and when you teach that, how conscious is that semi-swarm model, or hopefully insert better word than semi-swarm model here? Like how much do you think about that?
It's interesting that you asked that question. It does predate me. So my mentor, Dr. Dan Howes, who is probably about, I want to say 15 to 20 years my senior. He's the head of our critical care unit. He played a pivotal role in introducing the RACE team to our hospital. But in Ontario anyway, RACE teams and RACE team variants, critical care response teams are quite common. But of course, every hospital does it a little bit differently. In some hospitals, it's owned completely by critical care, and a critical care response team consultation sometimes looks an awful lot like an ICU consultation. In our center, it's a little bit different than that, because we do have physicians who work both in the ICU, but also in the emergency department. And so there's maybe it's a bit different than some other models. But not having worked in the United States myself, and not having worked on a critical care response team at other hospitals, I can't speak, I can't tell you precisely how it's done, but certainly in our model, we try to be conscious of all of the issues that you mentioned, and we see ourselves both as resuscitationists primarily, but of course also as individuals with a certain amount of expertise that we want to share, that we want to educate our young house staff to kind of make them more confident in their roles, to provide the support they need. The feedback we've had has been uniformly positive from that model.
So take me a little bit deeper into that. So you're on the urology floor, the patient's in flash pulmonary edema. You all decide that you're able to stabilize the patient, mostly with a little bit of BiPAP. You don't need to intubate the person. Their vitals start improving, and you're getting ready to do, the way that we would do it is to say, okay, code 4, ER team clear, we go back to our normal work. What do you do right then? How do you use that moment? Is it right then? Do you do after action reports like a week later, or what's your setup for that?
Do you mean from an education perspective?
Right. So your second mission, or whatever you want to call it, in terms of your ability to raise all of the ships around you.
Yeah, so I mean, again, it's going to be different from faculty to faculty, but my approach is always to do the in the moment teaching. So I'll provide suggestions as we go, but when the situation is all done and the patient's been stabilized, we've decided if they're staying, where they are, if they're moving to the step down ICU. At that point, I specifically spend my time with the resident who's been kind of leading. And I spend a few minutes talking about, here are the options for flash pulmonary edema, and I talk about recognition a lot. We talk a bit about communication. One of the typical things that I find is I'll arrive to a situation like that where things are, when anxieties are a little bit high, the patient's not doing well. And oftentimes a very well-meaning nurse or very well-meaning junior resident will start to give me a long story about what's been happening with this patient. This patient is post-op day 11 for this, and this is how their OR went. You're smiling because you've been there, right?
Right. Yeah.
And there's lots of great details, but there's only a few things I want to know, right? I want to know that the patient was, hypoxic over the last, couple hours, was really hypertensive, woke up kind of anxious. And really that's all I really need to know. And then I'll look at the vital signs and essentially what we do there is this concurrent diagnostic and management plan, right? And of course, as in medical school, you're taught to, introduce yourself to the patient and then, get a history. And then after your history is done, think about your past medical history and the allergies and the medications, and then you get the vital signs, and then you examine the patient, and you brainstorm a differential diagnosis, and then you go ahead and order a few tests, and the tests come back, and then you analyze the results, and then you decide what you want to do. You call this, pulmonary edema, and then these are your treatments, right? But in the real world, that's not practical and not safe. We take a kind of a non-linear concurrent approach to this. And so after many of these cases, I'll talk to the resident and I'll say, okay, well, let's just think about the things that are kind of most relevant here. Well, what's most relevant is the patient is in respiratory distress. Their stats are kind of crummy, their blood pressure is up. That's really all we need to know in order to do the first few things, right? So when you see a patient like this or any sick patient, here are the 3 or 4 things that you always need to do that are always useful. Number 1, it's always called the racing. And then number 2, it's put some BiPAP on this patient. Let's make sure we have IVs. Let's make sure we have a good set of vital signs. Let's make sure we have the help we need in the room. And once you have that, I mean, you've dealt with, the first few minutes of any scenario, and then you can start to hone things down. And so I spent a lot of time talking about recognition and initial approach. And, we can get into that. There's the whole science of recognition, prime decision making, and system 1, system 2. And yeah, there you go, Gary Klein. Yeah, exactly. Yeah, you're all over it. Yeah. So yeah, so we talk about that because I think it's quite relevant. And anyway, I can talk forever. Maybe I'll stop now and let you.
Yeah, let's fracture that into a couple of different places. So since you all can't see us at the moment, I just held up a book called Sources of Power by Gary Klein, which is sort of one of the leaders of the recognition prime decision model, decision-making model of the universe, which talks about how experts make decisions. And I hope we're going to dig into that in just a minute too. But man, there's so many little things in that. And first off, I wish we could have seen my heart rate as you were describing the long list of things that a medical student is supposed to do for a patient in an emergency, because it probably just would have been more and more up. And I'm getting more antsy as I'm watching this person take a really detailed, slow history, because there really are 2 gears, right? There's the gear of like the slow diagnostician, and then there's the gear of emergency. And that really creates a different need for basically everything, like how you process and gather information, how you decide things, the risk-benefit ratios of things, your priors from a Bayesian statistical point of view. Basically, everything has to change. And so maybe that's a great place to start the next phase of this conversation, which is that you have to understand in some sense that you are actually in an emergency. You have to realize, okay, now I need to put on my second brain, or whatever you want to call it. So how do you do that? How do you recognize that you're in an emergency? How do experts do it differently than beginners? How do we train people to do that? How did you learn how to do that? I don't know, man. Pick one of those and run with it. Let's see what we can build.
Yeah, sure. So maybe I'll just start talking. I mean, I think the first thing is you have to understand that perfection can be the enemy of good, and I think that is really important. And sometimes when we get into our rabbit holes and into our kind of silos of expertise, we can really, another analogy and metaphor, lose the forest through the trees, right? I think you need to understand when you're in an acute emergency, and then, like you said, change gears, right? So if that patient is not looking well to you, you need to listen to that, right? And there's some good research that suggests, and also just clinical experience, the first thing that you do when you walk into a patient room is to see if that person looks sick or not sick. And learners develop that relatively early, I think. Not right away, but within the first year of residency, residents can tell if someone looks like death or not. And I think if you're recognizing that, I think you need to listen to that and then put your emergency hat on. And then, just focus on, a couple of things that you need to know. The classic thing again is, your cardiac arrest patient, right? All I want to know when that patient rolls through the door with EMS is, how long have they been down and what has their rhythm been? Really, nothing else matters than the first 5-10 minutes of that case, most of the time. Yeah.
But recognizing that is crucially important, right? Recognizing when you're in a situation where you don't need information, you just need one piece and then action, versus I'm in a situation where I need to gather lots of information, is in and of itself a skill, I think.
It is a skill, and it's something that we're all taught and learned through experience. And then I've struggled with this idea of whether or not that's something that we can teach earlier or not, or whether that just has to come with time, right? I'll give you another example. In some of our simulation work, we create a case where a patient has a ruptured AAA and abdominal aortic aneurysm, and it's there's no diagnostic dilemma. It's really obvious this person's hypotensive, has a history of this AAA, and they're bleeding to death intra-abdominally as a result, or retroperitoneally as a result of this aorta. And one of the really interesting things that we found is that junior learners will try to take all the information they're given in the simulation because they think they need to use it, whereas experts have a bit of a different approach. So that junior learner, for example, will get all of the typical pieces of information that the more expert will. So for example, they'll come in, they'll get their vital signs, they get a list of medications and allergies, whatever. And oftentimes in the workup of a very sick patient, an ECG is done very early on before we know what's going on with the patient at our center. And so what we did is we gave participants the ECG from this patient within 30 seconds of them arriving. And it's fascinating to watch what happens in the simulation. And this is exactly what happens in the real world. The junior resident takes the ECG and sees a bunch of ST depression everywhere and thinks, okay, well, this might be acute coronary syndrome and I need to act on this. And they're spending some time analyzing this. And while they're analyzing, things are going on. Blood pressures are coming down and heart rates are going up and the patient is looking worse and worse. The team has questions, but again, that person is focused on the ECG. Whereas the more expert, whether or not he or she looks at the ECG is a bit irrelevant because they've already identified what's going on. The ST depression is not ACS, it's of course demand ischemia, but it makes no difference in this case. The ECG is not relevant, so they politely say, thank you very much for the ECG, they put it aside, and then they go ahead and call the vascular surgeon, right? So can you teach that? I think you can teach it, but of course, that may be different in another scenario, right? So if you have a slightly different simulation, actually that ECG is the most important thing. I think it takes a bit of expertise and experience to develop that. I think we need to teach junior learners that it's okay to deviate from what they've been taught. But I think you need to spend some time in an emergency department and thinking about your approach to patients before you can confidently disregard information. We talk about information reduction, and that maybe that's something you and I can talk about in a little bit, but you need to have a certain amount of expertise before you can rely on that because you may miss certain things.
It sounds like a great case, like an absolutely great case. And that metric of time to discard of the EKG is a fascinating metric to measure for people, which maybe gets into an interesting idea of like, how do you actually measure expertise?
Great question. I think it depends on what domain you're talking about. So there are certain domains where it's a lot easier to measure expertise and others where it's very difficult. So in our world, I think you and I both know a good resuscitationist when we see one. Mm-hmm. But it's really difficult for us to describe what makes that person good, to put it into words. And similarly, for the actual physician, him or herself, it is a bit tough to explain what makes them good and how they've changed over time. Unless you've done a lot of introspection and a lot of reflection and reading about this, it's not obvious. Whereas in a game like chess, where each board, every position on the board has a best move associated with it, right? You can measure what somebody does and compare it to that best move in a readily quantifiable way, and that's easy to do. So I think it depends on your domain. So how do you do it in resuscitation medicine? We've struggled with this over the years, but we've come up with a couple of solutions, and we've published a few papers on this. But we think the best way to look at this is through cognitive task analysis. Essentially what that means is getting someone to narrate his or her thoughts and looking at what their actions are in a busy resuscitation case. Now, it's not practical to do that in the moment because there's a patient's life at stake. And so you can't really say, well, I want you to kind of go through all your thoughts while you're resuscitating this patient. That would be completely unethical. But what you can do is you can, one, videotape, and two, better yet, what we've done is to put eye tracking glasses on physicians that record audio, video, and also pupil position in real time. And you can show the video to the physicians afterwards and say, okay, now we're relaxed, the case is over. Let's delve into this. All right, so I noticed that you were looking at the patient's vital signs and then you had actions A, B, and C. Why is that? What were you thinking here? What was going through your mind? And then there's a whole bunch of other actions we can look at as well, and interview them and kind of try to really hone in on the kind of the reasons behind the actions. And when you do that, you find really interesting things, and you can qualitatively and to some degree quantitatively look at the differences between experts and novices based on that cognitive task analysis. And the reason that's important, I think, is because if you have a fairly straightforward resuscitation and the outcome is the same, so the patient becomes intubated at the end, let's say your endpoint is intubation. If it was an easy intubation, then both the fairly junior person and the expert person will both have checked that box. Patient intubated, first pass, great. But if you actually interview and try to get into the thinking process behind that expert and that novice, you may see something different. You may see that the novice thought about the plan, successfully went through the plan, intubated the patient, great, but there wasn't a lot of deeper thinking underneath that, right? So maybe the expert thought of that exact same plan, but had a plan B and a plan C ready for when plan A fails, because plan A, though it's going to work 95% of the time, for the 5% of the time that it's not going to work, I don't want to be thinking of my plan B at that point. I want to have already thought of what plan B is going to be. And the only way to uncover that is to delve into, the thought process, because tons of this stuff is under the surface. And that's why it's, OSCE checklists in simulation cases have some value, but they only tell you about competence and kind of that first stage of expertise. If you really want to get into the nitty gritty, you've got to figure out what people are thinking, because they're not verbalizing all of these important thoughts.
And how aware of that do you think that either you or we are in general when we're doing resuscitations? I mean, if you asked me, I guess what I'm saying is I can sometimes be able to narrate my thoughts, and sometimes afterwards I imagine I'd have trouble with that, because even below the level of my thought is my sort of unconscious thought, my unconscious pattern matching systems, which either systems one or recognition, prime decision making, whatever you want to call it, some of which are by definition not really touchable from my conscious thought. Is there signal in that, or is most of what we're looking at sort of in the I don't know, the intermediate basement level?
So I think some of it, I think most of it is retrievable. I think you're right. Some of it may not be. And I think as expertise, as you get further to the right on the expertise spectrum, experts do to some degree develop what's called an expert blind spot, which is a bit, self-explanatory in the sense that you may not be aware of all the great things you're doing because it's so obvious to you, right? But I think with a cognitive task analysis that's done by a trained interviewer who is also an emergency physician in this case, who has some training in how to properly do a cognitive task analysis, I think you can dig those things out, because and especially with eye tracking, when I can watch what someone's eye patterns are during a case, I've been there. So, though I may not know exactly what they're thinking, I'll at least know that they've done something interesting that I need to ask them about. Whereas if you don't have that training, I think it becomes a little more difficult. So I think having that congruency between the interviewer and the interviewee is important.
All right, so maybe this is a good time to shift gears really slightly, and we've been dancing around for a while this concept of cognitive load. So what is cognitive load? How do we measure it? What do we do about it? And what do people listening to this podcast need to know about it?
Yeah, so cognitive load essentially is the amount of your working memory that you're using to accomplish a task. That's how I think of cognitive load. And cognitive load theory itself is a theory of education. It's an educational psychology theory that some psychology giants created about 30 years ago now, in the late 80s, early 90s. So these three guys, John Sweller, Jeroen van Marienboer, and Fred Pass, were some of the first to kind of put this together, John Sweller being the pioneer. Essentially, it's a theory of education where if we understand the way our working memory works and understanding the limitations of our working memory, we can create educational interventions that optimize certain aspects of it and minimize others. So what I mean by that is there's an intrinsic cognitive load that's associated with learning a task, and that's called the element interactivity, or essentially the difficulty of the task to be learned. Then there are extraneous bits of cognitive load. Essentially, what that refers to are suboptimal information presentation techniques. So if you have a suboptimal teacher or teaching technique that doesn't that essentially is confusing, let's say, that's going to lead to poor learning, and those things are additive. And so the more difficult the situation is, and the worse way that it's presented, that's going to increase cognitive load. And if you get to a certain point, you're going to reach a state of cognitive overload where you're not going to learn anything from that teaching intervention. And that's cognitive load theory in a nutshell when it comes to education. And that's how cognitive load theory was born and how it's been applied most of the time. But recently we've been thinking about that in our world and applying it to clinical medicine, because I think there are some direct parallels that can be made between cognitive load theory as an educational modality, as well as cognitive load theory in the real world. And I think that's where it gets exciting.
Okay, so let's translate that theoretical concept to our real world emergency department. So we're in an emergency department. We have a sick patient in front of us. Let's make it, for fun in quotes, a COVID patient who's really having a lot of trouble breathing, and we're sort of making a decision about, do we need to be aggressive and intubate this person, or is there sort of other paths we can take? And there's a lot involved in that decision, but help me map that, what you just said about cognitive load theory in education, into this situation, which I'm standing in front of.
Okay, great question. So in a complicated situation like that, there's a lot of intrinsic cognitive load, first of all, and that's for everybody. That's not just for novices who maybe don't have a lot of experience with this, but now for experts, this is a novel situation where, though we all know how to intubate and how to take care of sick patients, there's a bit of added complexity here, right? So even the decision making is a bit different, right? So am I going to, for the same oxygen saturation and work of breathing where I would have intubated somebody before, do I do it now? It's not totally clear. Maybe not, right? And if I'm going to do it, I'm not going to do it in the way that I've always done it. There's going to be a protected intubation, right? So there's some intrinsic elements of that medical encounter that are more difficult. So your intrinsic cognitive load is going to be higher because of the intrinsic nature of the medical problem that you're faced with. So if working memory is a box, your intrinsic cognitive load for your non-COVID intubation is, this big, so small. And now it's going to be a little bit bigger. And then there's a box for extraneous cognitive load, right? So extraneous cognitive load has to do with some of the distractors, right? So some of this has to do with the fact that, maybe there's an overhead page about a code blue for a patient who's not in the emergency department, but in our shop, we hear these overhead code blues in the emerge as well for whatever crazy reason. But that's now extraneous load. That's a distraction that's not relevant for what you're doing in the moment. And that's also taking part of your working memory because you're processing that stimulus and you're choosing to ignore it. And then, of course, there is the emotional response, the stress, and the uncertainty that this COVID patient instills in you as a physician and in your team as well, because there is added stress there because now there's team safety that we're thinking about and all of the issues related to that. So then it's interesting, do those issues, those effective concerns that I just mentioned, that stress, that uncertainty, is that extraneous? Is that a distraction, or is it intrinsic to the actual case itself? And what we're finding, and what our new theoretical model suggests, is that is probably intrinsic to the case. It's not really a distraction, though you need to, be in your PPE, though you're hot, in your gown and your N95 and in your visor. That is now part of the new medical problem, right? That is associated with that. If you wanted to create a simulation to train your team, what you should do is put your team in that PPE so they know what it feels like. Those issues that you might think are distractors are actually part of the case. They're now a part of intubating this patient, whereas they wouldn't be for this same patient a year and a half ago. So I think it's important to be able to compartmentalize what is intrinsic to the case and what is extraneous, because you can't, though you want to minimize extraneous distractions, and you don't necessarily want to train for those, you never want to minimize kind of the stress and the heat and the anxiety of being the physician in charge of a case like this. You want to simulate that. You want to show people what it's like. You want to teach them mitigation strategies to deal with those kind of additional strains on their working memory. So that's where I think it's important to take the theoretical model and to apply it to the real world so that you can make systems changes.
I'm thinking about, I think it was episode, 11 or something, with Andrew Ayer, who's a faculty member at Brigham and Women's and formerly worked with the Stratus Center for Simulation in Boston, and talks a lot about the idea of consciously setting the signal to noise ratio in a particular simulation case. So he's like, here's what I want people to try to accomplish. And then depending on their level, I'm going to add noise on top of that in one form or another, either physical, actually he'll play noise in the background, or sort of the idea of getting extraneous pieces of information or screaming family members or something like that. And it's an interesting thing to think through, both in terms of how do we design optimal training that allows people to slowly ramp up their capacity to handle that, versus what systems do we have in place like right now that'll allow us to handle that if you or I were dropped into that situation tomorrow. And I just want to make sort of one thing slightly that is implicit, slightly explicit, to make sure I understand this. So the way you're describing that, things that are intrinsic cognitive load are parts of the situation that we cannot change, and we cannot necessarily, well, actually I'll ask, can we touch those? Can I change the intrinsic cognitive load of a situation, or only can I change the extrinsic cognitive load?
So you can change intrinsic cognitive load if you're better prepared, if you're smarter, we'll say, if you've done your reading, and if you're more expert, right? So as expertise develops, as you practice more and more of a situation like that, whether it's in simulation, in the real world, or both, you can start to decrease the amount of working memory that's dedicated to intrinsic cognitive load, because the case becomes easier to you, right? So there, we can go into the theory, but essentially it just becomes easier because you've done it before, you've thought about it before, right? The extraneous factors are things that you should be able to diminish. If you had power over everything, if you had power over muting, the speaker that's right above, where I'm standing in my resuscitation bay, that's telling me about the code blue on the 9th floor of the hospital that I don't care about, that's something that if you had the power to change that extraneous cognitive load is gone, right? So that is something you can change, and you should be able to change. Then there's other parts of extraneous cognitive load that you might not be able to change, right? Maybe, not as part of your current situation, you're not stressed out by that, let's say, but let's say you've just had a fight, with your partner, or there's some kind of stressful event at home or with your kids or friends. That's something that may be a bit more difficult to just turn off. To some degree, there are strategies for that as well, and some people are better able or not better able to do that. But those are real things as well that have an impact on your working memory to some degree as well.
So the things that we can do to change the intrinsic cognitive load are things we do essentially on our days off. They're things we do before the shift. They're things we do when we're studying and practicing and training. But when we're actually in the moment of that case, they're sort of untouchable in that moment, as opposed to the extrinsic cognitive load, which we can deploy countermeasures essentially, and we can train countermeasures to deploy against certain pieces of extrinsic cognitive load. Am I getting that right?
Yeah, that is correct. Yeah, that's right. Now, just to be clear, a purist would call it extraneous, not extrinsic, but it's
okay.
It's the same thing.
Interesting. And is that because extraneous versus extrin? I'm gonna butcher both of those words right now, but is that because some of it comes from outside of me versus inside of me? Or is that because
I think it's just the terminology that was decided upon when the theory was first being written. So it honestly, in the real world, it doesn't really matter.
Gotcha.
The purist might stop you.
Okay, so we have these different types of cognitive load, and we need to be aware of them and to develop techniques that allow us to minimize them, because the more capacity we have, the better able we are to not only deploy our normal procedures, but also to think creatively and sort of get around obstacles. Is that right also?
Yeah, that's precisely right. So when you think about that working memory box that has intrinsic load in it and extraneous load in it, if intrinsic and extraneous is more than your working memory capacity, you're overloaded, you're cognitively overloaded, and your performance will suffer, right? Full stop. If you're able to manage your intrinsic and your extraneous load and you have more free working memory available to you, that's when you might you can think a bit outside the box. You could think creatively. You could think about the patient next door. You can perhaps do a little bit of teaching, if you've got a resident or a medical student with you. Maybe you can bring the family in, and maybe you can spend a little bit of your brain power on communicating with the family and explaining the situation. While things are still going on, you're kind of co-managing the medical care as well as some of those important that relationship that you're creating with this family member who's really worried about their loved one. So those are things that you can do if you do have that extra cognitive capacity.
And this sort of brings us, in some sense, you're describing basically like the Yerkes-Dodson curve, right? The idea that like however much pressure we're under changes our performance in it. And no pressure, we're bored and we don't perform too well. And at extreme amounts of pressure and overload, we get what Stephen Hearns would call frazzle. Like we get in that frazzle state and we're unable to really function. And what's so interesting about this, and maybe so obvious to you, I'm thinking about it a lot, but like just dissecting load into intrinsic and I'm going to say extrinsic again. I know that's not the right word. I'm sorry. Extrinsic load, that both of them push us on the curve. And to some extent, I would wonder, like, do you think they push us the same amount? Do you think they push us different amounts? It's probably nonlinear. How do we, like, knowing that, what do we do about that?
Yeah, so I think there's kind of two questions. Is it linear or quadratic? And there's actually it depends on how much you want this to become a psychologically kind of educational psychology nerdy talk. We can get into that, but there was a recent paper that looked at whether it was linear or not. Anyway, probably not relevant. But conceptually they're additive, right? So the less extraneous cognitive load, the better, and the more optimized you can be, the more ready you can be for a complicated scenario and to deal with intrinsic cognitive load, the better, right? And if you're not prepared, or if a situation is totally novel to you, or you're really stressed by the scenario, or there's a whole lot of distractors, that's going to have an impact on your performance. And of course, then this relates to our previous discussion. There's outwardly visible performance, and then there's what's going on under the hood. So even if my outwardly visible performance is similar, if I haven't prepared as well for contingencies, then I'm not doing as good of a job as a team leader, even if nobody else knows it except me.
That's for sure. I'm flashing back to a couple of cases I've had recently where I realized, hey, there's a lot of, this feels uncomfortable to me. I am aware that I'm not performing in my sort of normal smooth set. And in those instances, I think deploying countermeasures against this external or extrinsic, or, man, I'm sorry, I'll learn that word eventually.
Okay.
Extraneous cognitive load becomes even more important. So tell me about that. So what are countermeasures? What can we deploy in that situation to minimize that load?
So yeah, good question again. So there are certain things that just happen with time, right? So there's two main things that I think about. So the first is essentially schema construction and automation, right? So when you were a medical student, when I was a medical student, and we learned about congestive heart failure, going back to our previous example, and pulmonary edema, we would think about things like, crackles on auscultation, high JVP. We would think about hypoxia. We knew these people were on diuretics, and maybe they had an echo that showed some poor cardiac contractility. And each of these was a discrete element in our working memory. And very quickly, by adding all those things up, we became a bit overwhelmed. We couldn't really remember what the treatment was, or We knew something about diuretics and positive pressure, but how to bring that all together was a bit complicated. But now that you've been doing this job for a while, the way you probably think about CHF and pulmonary edema is CHF presentation and CHF management, right? And that's it. And then so you've got a lot of other open areas in your working memory to do other things. Now I've lost track of my thought here, Dan. Where was I going with this?
Schema and automation.
Oh, there we go. Schema automation. Exactly. So you've created a schema for what CHF and pulmonary edema looks like. You've automated it, so it takes less of your cognitive load. So that's a way of decreasing intrinsic cognitive load with time. So that is experience, that is studying, that is taking care of patients with these issues, right? So that happens. And the other thing that happens with respect to your extraneous cognitive load is information reduction. I touched upon this earlier on. And essentially what that is what I described with the ECG example and the AAA rupture. So that information is extraneous to me at the time because I know that this is a patient who needs an operation for their aorta. So I know what to disregard. I know what to actively deprioritize, what is safe to actively deprioritize, and what I need to actually prioritize. And by deprioritizing irrelevant stimuli, I again have more working memory because I've decreased the amount of extraneous cognitive load. So that's the evolution over time, right? So that happens to all of us as we go from medical student to resident to attending and then senior attending. So that's going to happen hopefully. For some people who self-reflect a little bit, who avoid what Anders Ericsson would call arrested development, get better at that than others, whereas others are competent, but they never become true experts, and that's fine too. But that's a natural process that maybe we can intervene on and help educate to speed up to some degree, but probably most of it is just going to happen with time, and there's nothing we can do about it. So that's kind of that's what's going to happen over time. But you're asking, what are some practical strategies that you can change, tomorrow? That's more difficult, right? Mm-hmm. So there are certain things that you can change if you sit on committees and you can talk to people who have power when it comes to, turning off that speaker in the resuscitation bay. Some other departments use some really great strategies where, not specifically for resuscitation, but just in emergency medicine in general, where they have, when the physician is wearing a red hat or whatever, a purple hat, that person is not to be interrupted because let's say they are either charting or they're ordering investigations or whatever they're doing. And that way, maybe you can decrease that extraneous load. In other hospitals, they'll have a specific computer terminal that maybe is kind of walled off in some way. So the nurses and the residents and the other attending physicians know that when that person is in that room, they are not to be interrupted unless there is a true in quotation marks, medical emergency where they need to be pulled away. So those are practical ways where you can decrease extraneous cognitive load tomorrow on your shift. But again, that's not just you. That has to be you and your group of staff. There needs to be some education that goes with that. But those are ways to decrease that load to make yourself a better performer under stress.
Yeah. So in some sense, the sterile cockpit rule is what you're describing.
Yeah,
right?
Exactly.
Right. The idea that in aviation, when you're below a certain height, the only communication is mission-centric communication about either taking off or landing the plane. And there's a great piece from MCRIT, I think it is, talking about the sterile cockpit in terms of intubation and creating a time and space where you say, all right, team, like we are now in sterile cockpit, go. And that sort of allows the whole team to understand that this is a time when I'm going to be focused only on this one thing and try to minimize that everything else going on around you.
No, you're right, Dan. And as you say that, I just am remembering a case I had last week where we were intubating a patient on the race team again on the floor, and so I was at the foot of the bed, and the anesthesia resident was at the head of the bed, and the drugs were pushed, the induction agent, the paralytic, and I could still hear the same chatter that was going on, and it's no fault of the people who were talking, they maybe weren't aware of what was going on. And a technique that I use, I don't use sterile cockpit, I use we're under 10,000 feet, and I'm not the first person to use that term, but for people who maybe aren't familiar with the science, people generally know what that means. We're under 10,000 feet, the only person who is going to be speaking is the anesthesia resident for the next 3 minutes. That seems to work for me. You could have your own version of that, but that's a way for me to help decrease the extraneous cognitive load on the anesthesiologist who is intubating, right? So that's a way for me as a leader, even though I'm hands off, to create an environment that's set up for success.
Yeah, and that's such a great point, which is that like understanding the more people in the room that understand cognitive load theory and how it works, the better able we are to decrease the load on the operator of the moment. And I think that that's a really crucial thing that we can intervene on, is to teach more and more people about this, right? So if everybody's proactively looking for high cognitive load situations and realizing like, hey, okay, I need to make sure that I'm not going to contribute to this load right now, the better. But also the role of an individual leader to say, okay, this is what we're doing now, like quiet, please. A better way to say that, of course, but I think that's really important.
Yeah, and I think then, the other thing that goes with that is social capital, and trying to make sure that you are only employing a vertical leadership style, which is what we're sort of discussing here, when it's absolutely necessary, is really important. Because if you're always a vertical leader, that becomes problematic. It's the boy who cried wolf, right? So when it actually matters and you're continuing to be a vertical leader, people aren't going to take it as seriously. Whereas if you're more of a horizontal leader, most of the time when it's appropriate to do so, for the times that you have to become a vertical leader, people will listen, pay attention, because they know that this is a different scenario.
To me, this goes back to that same book by Marquette about Turn the Ship Around, where he talked a lot about changing from a leader-follow model to a leader-leader motto. And when they did the final evaluation of his submarine, what they said was essentially like, your team attempted to make the same number of mistakes as all other teams did. However, you had systems in place of horizontal leadership and everybody knowing the shared mental model of what you're trying to do that prevented those mistakes from actually being carried out, which I thought was a really fascinating way to put that. Like, because in some sense, that's what we're talking about. We're talking about sharing the mental model of what's happening with the entire room and making sure everybody's on board and understands the details of what we're trying to accomplish.
Yeah, exactly.
So much to dig into there. We're gonna have to do another like deep dive into some of this, like opening up more of these boxes and looking at the machinery a little bit. I think I'm learning a ton from this. But we're coming up amazingly to the end of an hour already, and so I want to be mindful of our time here and close us out with a challenge. So what is your challenge to people listening to this? What is something that they can be working on this week to get better and to bend on the curve for their team?
Well, I think, like you said, you can do lots of different kind of cool things with this work. I think, of course, I'm biased, but one practical thing that I think everybody can get behind is decreasing extraneous load on yourself and on your team. If you're in a shop like mine, so my major annoyance, and I have to say I'm guilty that I haven't followed through on trying to get rid of this, but the overhead pages for codes in other areas of the hospital that nobody in the emergency department is supposed to attend to, when that message comes on the loudspeaker, during an intubation, let's say, that is something that it needs to go, and that is something that I'm going to work on moving forward. So, you asked for my challenge to others. Well, that's my challenge to myself, but I'm sure others listening will find similar issues at their shops when it comes to decreasing extraneous load. Maybe it's that sterile cockpit model when you're charting or thinking or ordering specific tests. Maybe nobody interrupts you because you're wearing a certain colored hat or you're at a specific computer terminal. So the challenge would be, try to find one thing where you can decrease the extraneous load on yourself and on your team, and try to follow up with the people who can make actionable change.
Awesome. Adam, thank you so much. I learned a ton from this conversation, and just a total joy to have you on the podcast. Thank you.
You're welcome, Dan. Thanks for inviting me along.
Okay, folks, that brings us to the end of this conversation. I hope you enjoyed it. I hope you found something useful that you can use next time you find yourself in an emergency or a crisis. Again, if you want to dig deeper into a lot of the concepts that we covered here, sign up for the Emergency Mind newsletter, Knowledge Under Pressure. It is free and it is awesome. You can join by going to www.emergencymind.com/signup. Also, as a reminder, our mission here at the Emergency Mind is to dig into lessons around applying knowledge under pressure, not to provide medical advice. Our opinions, as expressed on this podcast or elsewhere, are our own and not necessarily those of our employers or the hospitals at which we work. So keep up the good work, keep training, and good luck out there.